Well, ladies and gentlemen, you have heard several lectures giving you the state-of-the-art and the most updated technology in removal of polyps using various new endoscopes and imaging modalities. Now I'm going to discuss with you in our real-life endoscopy, where we are still using the conventional endoscope with the high-resolution lens. How can we improve our detection? First of all, let me recapitulate that to prevent colorectal cancer, the single most effective strategy is still to find the polyps and remove them. And this has been, in the last few years, confirmed and reconfirmed by a few very important studies, including the National Polyp Studies, and Dr. Jerry Wei is in the audience. You can see that by removing the polyp, you can substantially reduce the rate of subsequent development of colorectal cancer and its mortality, although it is still slightly higher than those who have never found to have polyps in this cohort study. And then other questions about prevention of colorectal cancer is that colonoscopy can only prevent distal colorectal cancer. In this study, they argue that both proximal and distal cancer can be reduced if one gone through a lower endoscopy and successfully removed all the polyps. So I think this is the gold standard until now. And another paper also telling us that screening with whatever method that you use and remove the polyps will be the single most effective way to reduce mortality of colorectal cancer. And this is a 30-year follow-up study. So why would still worry about colorectal cancer, especially after colonoscopy? And a lot of discussion and even debate recently is on interval cancer. What is the definition of interval cancer itself can be a one-hour talk, so I'm not going to take you through this. Basically, what we mean is between one endoscopic examination and another, somehow patients developed a cancer, which is a very bad news for both the patient and the clinician. And this is a study published very recently from a large cohort of over 9,000 subjects from 8 colonoscopy centers, and follow up for 4 years, and they found a number of patients with interval cancer. And the reasons for interval cancer, according to this study, can be divided into missed lesion, which occupies more than 50%. So we have to reduce missed lesion. New lesions by fast-growing tumor is another possibility, and incomplete removal of polyps, especially large polyps, constitute the rest of the cases. So are we actually seeing fast-growing lesions that may explain interval cancers? Well, I think this study can give us some hint on this. In 1,323 colorectal cancer in the registry of this study, the authors have divided the interval cancer versus non-interval cancers and look at the location and the underlying pathology or the mutation. And you will see that definitely interval cancers are found more commonly in the proximal part of the colon, and they are more likely to have CIMP or MSI mutations in these tumors. And this represents a group of tumor which can be growing faster than the more common type of colorectal cancer. And they are also probably more commonly found in the proximal colon. And again, this paper I have already mentioned before, they also identify 62 cancers which were diagnosed within 5 years after colonoscopy. So it falls into the definition of interval cancer. Once again, the CIMP mutation and the MSI high, its type mutation is found to be more common among these patients. So indeed, we do see occasionally patients have rapidly growing tumors which can appear again before patients undergoing a second screening or a surveillance examination. Incomplete removal, as mentioned by Dr. Saunders, is a very important issue that every colonoscopist has to face, because if we resect a tumor incompletely, leaving behind a small piece which can grow into a malignant tumor, then no wonder patients will develop early cancer. And the size of the polyp has a positive correlation with the chance of incompleteness. You can see the larger the polyp, the more likely that we have not done a complete job. And also, because of the size and its morphological nature, the sessile serrated polyps are more likely to be incompletely removed. So we have to pay special attention to this, and we have to follow the newest technology, how to perform the cleanest colonoscopic polypectomy. But by far, I think most important issues that all of us have to deal with is how not to miss a lesion, which we should be able to find on a conventional colonoscopy. And it has been estimated up to 17% of the polyps in the colon has been missed, larger than 1 centimeter. And it is more commonly occurred in the proximal colon. And this paper, I'm sure it's very familiar to all of you, is the first time, the first study indicating that how careful we are in examining the colon have a great impact on pickup rate of the adenoma. If you plot the number of colonoscopies performance in a quantile pattern like this, you will find that there are a wide range of the adenoma detection rate. And the adenoma detection rate will have a very strong and important correlation with interval cancer subsequently found among these patients. So you can see that if the adenoma detection rate is lower in the range of single digits or up to 20%, then you will have a much higher chance of having interval cancer, and the relationship just goes in the reverse direction. Therefore, now we are more and more keen to talk about adenoma detection, which, according to the ASGE, now is defined as a term applied only to average risk subjects over the age of 50 undergoing screening colonoscopy. So we are not talking about people who have symptoms, people who comes in for a plial bleeding and we perform a colonoscopy. These are screening subjects, and the colonoscopist performing this procedure will accumulate the data and come up with his ADR, which is defined as the number of patients with at least one adenoma divided by the number of screening colonoscopy that he has performed. And the target that is been now set as a national or international target is to have 25% of ADR, which may be slightly higher in men of 30% and 20% in women. And this is set to be the target for ADR. If one cannot reach this target in its adenoma detection, the performance of the colonoscopy has room for improvement. And how to achieve a higher ADR among our colonoscopists? First of all, we will have to reduce or prolong the withdrawal time up to 8 to 10 minutes from cecum to anus. And we will have to have a good bowel preparations so not to miss any proximal tumors. Retroflexion in the cecum is now being advocated, and training program for for screening colonoscopy has also been shown to improve the performance. So first of all, withdrawal time. You can see that the withdrawal time is in direct correlation with the number of adenomas detected, and also increase the chance of finding advanced neoplasm as well as cancer per se. And a question arises then, is it slower always the better? If 6 minutes is the minimum, how about 60 minutes? Can we stay there for an hour and increase our detection of adenoma? Well, the data is a little bit conflicting. It is not really that you stay there for 2 hours, you will get 200% increase in adenoma detection rate. However, in a quality assurance program done by Barclay and colleagues, they have found that if you use a stopwatch and automatically timing the colonoscopy withdrawal every 2 minutes from the cecum to ascending colon, and in 2 minutes in the transverse colon, and then 2 minutes in the descending and the sigmoid, and so on, you may be able to increase significantly the adenoma detection rate. And this is something that is interesting and worthwhile to consider. Can we use a training program to increase the adenoma detection rate? Wallace and colleagues in Florida have shown that, yes, indeed, training does seems to increase modestly the ADR. And however, conflicting ideas have also been produced. In any case, I think we will need to not just thinking about doing more colonoscopy, but to ensure quality of our endoscopy in the program. And the quality indicators listed here includes appropriate indication in over 80% of the patients, bowel preparations considered adequate in over 85%, cecal intubation, if not 100%, should be at least 95%, average withdrawal time over 6 minutes, and the performers should have adenoma detection rate of 25% overall, very few perforation, few post-polypectomy bleeding, and the interval between surveillance colonoscopy should also be tailored to the risk of developing these lesions. I would also say a few words on what kind of endoscopes or endoscopic imaging may be beneficial. And you have heard the newest technology, but what about the previous published data on existing imaging devices? Well, definitely high definition white light endoscopy has been proven to be useful in trained eyes to detect more adenomas. So it is worthwhile to invest on high definition white light endoscopes. The benefit of narrowband imaging has been a little bit less affirmative. There are studies which show that it may be better. There are studies which show that there is no difference, and the pooled data has not shown a remarkable difference in the outcome. Chromoendoscopy, as you have seen the video from Ralph and others, if under trained eyes and good conditions, the patients either using high definition or the standard white light will be able to find more adenomas, especially the flat or the difficult one in the proximal colon. So all in all, this is the kind of summary that I would put to you, that high definition white light and chromoendoscopy seems to give you more positive results overall compared to the other types of imaging modalities. Of course, these slides will be outdated very soon with the new modalities which is becoming available. Now, before I finish, I would like to tell you that if you have too many patients to screen and you want to give priority to people, then you would really like to select the high-risk population for earlier colonoscopy screening. And in Asia, we have tried to do that because we have the largest population of the 5 continents. And therefore, through a number of studies, we have come up with a scoring system in which the age, the gender, the family history, and smoking are now put together in a scoring system. And through this, patients will be classified as average, intermediate, or high risk. And the high risk patients have 4.3-fold increased chance of finding a neoplasm or advanced neoplasm in the colon. And we suggest that if resources and time is limited, priority should be given to this population for earlier screening. And we, in fact, have tested a dual approach or a hybrid approach of giving the high-risk population early colonoscopy screening, whereas the moderate to low risk, we will use, in fact, the FIT test, to hopefully pick up the positive cases. Then they would be given early colonoscopy, and the rest will just be tested annually or biannually. For the study designed, we will give them a routine colonoscopy to find out what we have missed. And in a study with over 5,000 subjects in Asia, we have come up with this interim result with low risk, moderate risk, which has either FIT positive or negative, and the high risk population who go straight for colonoscopy. And you can find that colonoscopy obviously pick up more advanced neoplasm and more cancer in the high risk population. But the focus should be on how many cases that we will miss if we do not perform colonoscopy but just use FIT for the moderate to low risk. And you can see that fortunately, most of the cases of moderate and low risk do have a FIT positive if they have advanced neoplasm or colorectal cancer. To put it more simply, we combine the low risk and moderate risk who have FIT negative as one group, and then the high risk people with a positive FIT in another group. These are the people who, by the protocol, will be given early colonoscopy. And the result shows that we have been able to pick up most of the cases of invasive cancer and twice as many advanced neoplasm compared to the low risk and the FIT negative. There were 2 cases of invasive cancer being missed by this strategy. So this is not perfect, but this is at least some way to triage patients for earlier colonoscopy if you really have too many patients to handle. And finally, family history, it's very important, especially in those subjects who have first-degree relatives who have found to have colorectal cancer. Studies have shown many, many times that these are the ones who may be having a higher risk of colorectal cancer. And the risk really depends on how many members and the age at which these family members develop colorectal cancer. And therefore, the time for screening should be adjusted according to the family history. And in Taiwan, it has been shown that the risk factor for colorectal adenoma is also associated with family history of colorectal cancer. For those who have family history positive adenoma, it's found in 2.5-fold higher in those family members, and the high-risk adenoma 4.5-fold higher. And we in Hong Kong have performed this study to look at people who have family members of colorectal cancer screened for adenoma compared to those without first-degree relatives screened for adenomas. And the results show that definitely siblings with patients who have colorectal cancer do have more adenomas, more advanced neoplasia, but because the number of invasive cancer was not high enough, we have not been able to detect a difference. So family members of colorectal cancer patients should be, receive more attention. And I would conclude my talk by emphasizing once again that if we want to prevent colorectal cancer, a proper colonoscopy with good quality assurance, good endoscopic techniques to remove the polyp is mandatory. And also in such a high population that we need to handle selecting high-risk subjects for screening and surveillance perhaps is necessary in many parts of the world. Thank you very much for your attention.
Thank you, Professor, for the excellent presentation. It's really, I find very rational to use the risk stratification when you have to deal with a so huge population in Asia. Do you have any questions from the audience?
Joseph, I mean, the risk stratification sounds extremely attractive as an option, but if you take fit positivity, you might be talking about 3 to 6% of your population. And then if you add in high-risk people on top of that, you're starting to get unmanageable numbers of colonoscopies, and you're kind of defeating the object of trying to reduce the number of people who get colonoscopy. It's spiraling almost out of control, isn't it?
Well, in fact, in our data, about 25% of patients belongs to the high-risk group, and in the rest of the patients, about 1/3 are fit positive. So the number is still lower than if we just subject everybody to the same waiting line for colonoscopy. So I agree that we may not be able to really select a very small group of patients for colonoscopy, but there is a payoff there. The more selective you are, the more cases that you will miss. So, and we will have to strike a balance in there.
But you're still colonoscoping 50% of your population.
Sorry?
You're still colonoscoping 50% of your population.
With this strategy, yes. Perhaps with the other tests coming in, for example, the stool DNA and so on, we may be able to narrow down the numbers. Of course, then you will argue that the money that we can save from that strategy may be not so impressive.
And just last questions about Professor. Could you just give us, just to recap, how can we really improve endoscopically? What is the optimal method or methods that we can try to increase the ADR? Because it's one of the fundamental quality indicator.
I hope that I have already portrayed for you that it is not just one thing or two things that we should focus on to improve the overall adenoma detection rate. At colonoscopy, screening should be considered as a program, so the center should have a proper protocol on the indication, on the bowel preparation, on the training of the staff, and also monitoring the ADR of individual colonoscopists. I think every steps should be considered in the quality controlled program of colorectal cancer screening. And it's not good enough just to say, well, let's have the whole country undergoing colorectal cancer screening with colonoscopy. It would, I think, causes a lot of trouble if we missed like 17% of cases with colorectal cancer.
Thank you very much. Thank you.